If you've not been on these calls yet, my name is Alice Bonner, and I chair the Coalition Conversation, it's a monthly series that's hosted by the Moving Forward Nursing Home Quality Coalition. And these conversations bring together leaders, researchers, practitioners, everybody to explore ideas together that can strengthen quality in nursing homes. The Moving Forward Coalition is a growing network of very dedicated individuals and organizations that are working together to improve care for nursing home residents and to better support staff and care partners. And we are generously supported by the John A. Hartford Foundation. So, as some of you are aware, we advance change through pilot programs, policy advocacy, public engagement, and we spotlight certain urgent issues like immigration for today through platforms like this one. We're joined by many wonderful partners on this call today, some of whom are members of the coalition. I know we have people from the Ombudsman program, we have people from our Michigan team, we have people from Massachusetts, and please chat in your name and your organization and your state if you'd like to. Just chat in who you are. And as you could see from the housekeeping, everybody's going to be muted while we have our presenter speaking, and then afterwards we'll have some Q&A and people will be able to raise their hands and ask to be unmuted, and then we'll get a conversation going. So today's session is focusing on the vital role of immigrant workers in nursing homes and the broader long-term care workforce. Immigrants make up more than 1 in 5 nursing home workers, and they contribute across, direct care, nutrition, housekeeping, administration, and operations. Their labor, their compassion, and cultural diversity are essential to ensuring that older adults and people with disabilities receive dignified, person-centered care. And at the same time, the long-term care sector is facing a deepening workforce crisis. And we know the challenges in one sector of the long-term care ecosystem impact all sectors, and that may leave people without access to quality care in different settings. So addressing this crisis requires bold solutions, better wages, safer working conditions, and career pathways that value and retain workers. And immigrant workers are central to these solutions. Yet they often face additional barriers, including restrictive immigration policies, visa limitations, and uncertainty around temporary protected status. So these challenges affect not only individual workers and their families, they also impact the stability and quality of care in nursing homes nationwide. So as we explore this topic today, we invite you to consider how immigration policy intersects with workforce development and the future of long-term care. Together, we can build a system that values every worker and ensures high quality care for every resident. So we are honored today to welcome Professor David Grabowski of Harvard Medical School, who's a leading expert in the economics of aging and long-term care, and he'll share his research and insights on these issues. By way of a brief introduction, Dr. Grabowski is a champion for long-term care quality, and he regularly testifies to Congress, participates in technical expert panels, and lends his time and voice to important initiatives aimed at improving long-term care and post-acute care. Dr. Grabowski served on the National Academy of Sciences, Engineering, and Medicine's Committee on the Quality of Care in Nursing Homes, and that's the committee that developed the NASEM report that guides the work of our coalition. He's also published over 240 peer-reviewed articles and speaks around the world. So Dr. Grabowski is going to share about his research and his ideas before we open it up to informal Q&A. So David, the floor is yours.
Great. Thank you so much, Alice. And hi, everyone. It's great to see so many familiar names as everybody was posting their names there. It was great to see so many friends and colleagues listed there. So I'm going to go ahead and share my screen, and hopefully this works. All right. Hopefully you can see that. Great. I'm seeing. Once again, thanks to Alice and Claire and Jennifer for inviting me today. I think immigration policy really is long-term care policy. It's so inextricably linked with all of the objectives that we hold around fostering a really, strong workforce. Alice mentioned this earlier that I served on the NASEM committee that made the recommendations that ultimately led to the formation of the Moving Forward Coalition. And although we didn't have a recommendation on immigration, I feel like immigration was a strong underpinning to all of these goals, but especially the first two. You need obviously sufficient staff to deliver person-centered care, and you need staff in the building that to support and to deliver that person-centered care. So I think if I was going to do this over again, I probably would have really pushed for a recommendation directly around immigration. But I do feel like this is really related. So once again, thanks to the Moving Forward team for including this today. I think all of you know this, but just as a way of thinking about the size of the nursing home workforce and how it sits in the broader long-term care ecosystem, um, there's many types of workers that Alice mentioned beyond direct caregivers and licensed practical nurses and registered nurses. There's dietary and housekeeping and all different types of administrators. These are the three main types of workers involved in direct care. Putting aside home care and residential care, although I will touch a little bit on home care in a bit. Um, the size of the nursing home workforce at any given time is quite large. We have nearly a 500,000 certified nurse aides, about 170,000 licensed practical nurses or LPNs, and then about 125,000 RNs. And I think most of us on the call are pretty familiar with RNs and LPNs and the role they play in the healthcare system. I just wanted to spend a slide on certified nurse aides because I think many folks, and maybe not necessarily the folks on this call, but many are less familiar. These are some data from PHI. They have a great workforce data center, and you can sort of play around with their data. And these are sort of recent data on the state of the CNA workforce. And most of this won't surprise you. The workforce is almost 90% female, predominantly non-white. I'm going to come back to foreign-born. Most don't have a degree past high school. Most don't have insurance, health insurance, that is, through their employer, or most have insurance, I should say, through an employer or a union, but that's just about half of them. This really kind of blows my mind. About 40% are on public assistance themselves. So oftentimes they're caring for Medicaid recipients, and some of these caregivers, these CNAs, may be on Medicaid themselves. About a fourth of the workforce is part-time. And then the average hourly wage is $18.16. So, depending on the state, there's quite a bit of variability, but in most states, they're kind of at or just above the minimum wage. And so this is not a high-paid workforce. I want to come back up to the information that's circled there. Alice already said this broadly, but I wanted to focus in on the CNAs. She said about 1 in 5 workers are immigrants or foreign born. That's true for the CNAs, 21%, according to these data. About two-thirds have been naturalized and are U.S. citizens, and about a third or 7% of the full workforce aren't U.S. citizens. Question always comes up when I raise this, how many are documented versus undocumented? Unfortunately, the data that we use and that PHI uses are called the American Community Survey, or the ACS. They don't actually have that variable, but when we've matched these data with other data, it's a pretty small share that are undocumented. The vast majority of those that aren't U.S. citizens are documented workers. So this is a very small share that are undocumented here. There's been pretty intense debate over the last decade or so about the role of immigrants in the U.S. economy, and this extends beyond nursing homes and long-term care. And critics, those against kind of immigration, claim more immigration is going to lower wages for native-born workers. It's going to increase our public welfare spending. It's going to lead to higher crime rates. Those who advocate for immigration, greater immigration, sort of resist the arguments that were just made about crime and wages, but then say, in addition to that, they're going to lead, immigrants are going to lead to greater innovation, economic growth, and also this opportunity to kind of balance our demographics. We obviously have this aging baby boom generation. It's very hard to fill in individuals in younger age cohorts, and immigration is an opportunity to do exactly that. There is a larger kind of literature, and I won't go through this in great detail, but there is this broader literature on immigration and um, different effects, whether you focus on higher paying jobs or lower paying jobs, those immigrating into those sectors. We generally see in the economics literature real positive effects from immigration for higher paying jobs, increased innovation, entrepreneurship, positive near-term effects on government budgets, and that these are not individuals typically on Medicaid, for example. The findings are a little bit more mixed when it's immigration for lower paying jobs. There's a set of studies that find small or even positive effects on wages and employment for those born in the US, and some negative effects on existing immigrants. So when more immigrants come, that leads to lower wages and employment for existing immigrants, little effect on public spending. There are other studies, however, that do find immigration for lower paying jobs leads to reduced employment and wages for US born workers and increased government spending. There's really kind of an unknown effect on the quality of labor due to immigration. Um, in terms of the healthcare literature, it's a little more narrow. There's some work suggesting immigration results in fewer older adults in nursing homes, and so presumably they can get care from home and community-based services or assisted living in the community. There's results, and I'm going to show you some more evidence on that from some of our research, that immigration results in more nursing home staff and better nursing home quality. And that's very consistent with the work our team has done, earlier work by Furtado and Ortega. And then finally, there's some work in the UK where the 2016 Brexit referendum sharply reduced immigration in the UK, led to fewer nurses working in hospitals and ultimately more readmissions. This is a there's a reason I'm speaking about this. I was telling Alice and the team before we got started that we started this research agenda long before everything that's been happening of late. But when we first started this, we just really wanted to test some of the issues around what happens when we see a spike in immigration. Maybe there's an opportunity to leverage greater immigration. Little did we know we were going to see maybe the opposite experiment, and that's exactly what we've been seeing. Lots of deportations, tightening border policies, and indeed, this is an evolving issue, if you will. There was I just took this sort of hot off the presses here. I just clipped this from the Boston Globe site over the weekend. ICE begins new surge in Boston as its deportation machinery hardens into place in New England. So ICE is the Immigration and Customs Enforcement, as most are aware. We also have Customs and Border Patrol, CBP. So a lot of emphasis, and you can see that on this next slide. This is just the ICE budget and projected out to 2026. And you see that massive spike where it's supposed to potentially triple. I couldn't find comparable data, although based on the president's budget and the reconciliation bill, it's also going to see a huge spike upwards. So we're going to see a massive increase in spending on immigration enforcement through ICE and the CBP in the coming years. How does this potential crackdown or tightening impact nursing homes? I just want to show you a couple of headlines here from recent stories over the summer. This was an AP story titled "Nursing Home Struggle with Trump's Immigration Crackdown." And there's a nice quote from Deek Katow, who's a CEO of three nursing homes in the Atlanta area, of which one-third of the staff are made up of foreign-born people from about 3 dozen countries. In his quote, "We feel completely beat up right now. The pipeline is getting smaller and smaller." Uh, a second story from July in the New York Times. This one, the quote, I think all of us know Katie Smith Sloan, the president of Leading Age. She suggested in the article that the Trump administration's immigration policies are already starting to disrupt facilities across the country as providers move to terminate some caregivers in recent weeks. And I underline this next because I think it really highlights how broad the implications can be from immigration policy. She said some employees had stopped showing up at work out of fear for themselves and their families. If there are fewer immigrants to fill positions, that could lead to nursing homes and assisted living facilities shutting down wings or closing their doors entirely, she said. And then finally, the quote at the bottom there, the services just won't be available for people when they need them because we won't be able to staff them. So I think Deke and Katie have already sort of highlighted some of this, but I think there's big potential impacts on the nursing home workforce from the current immigration crackdown. There's obviously the direct effects, and those are pretty obvious. Tighter immigration policies keep potential workers out of the U.S. or deporting current and future workers also diminishes the size of the workforce. But then there's these indirect effects that were sort of hinted at, at least in Katie's quote. Workers might quit or not show up for their shifts because of fear of ICE showing up to their workplace. This could lead to fewer individuals wanting to immigrate to the U.S. So this could actually lead to a smaller number of potential workers. And then finally, um, this could ultimately lead to closures of nursing homes or at least a loss of staffed beds. So that's kind of the current context. And I would love to say, well, we're overlaying this current context on a position of great strength, that we have all these staff and we're well positioned to withstand a loss in staff. And I think nothing could be further from the truth. These are some data that actually predate even the pandemic, but even prior to the pandemic, many nursing homes across the country were struggling with staffing. These are some data we published in Health Affairs, and we just examined how many nursing homes for how much of the time are below what CMS's Strive data would suggest that we would expect the nursing homes to have on site there. And you can see most nursing homes were below the Strive expected levels most of the time. Very few were meeting this for RNs, LPNs, CNAs, or across all of their staff. And it wasn't just that nursing homes had too few staff, it's that the staff were also turning over too often. This is another study we published in 2021, led by my colleague Ashvin Gandhi. And if you start on the left here, just the mean and median annual nursing home staffing rates, you can see that on average we have over 100% turnover. So the average nursing home was having all of their staff turnover. You can see it for RNs, LPNs, and CNAs. It's all on average above 100. But then I find the sort of the distribution on the right really disconcerting, in that, yes, there's some with 100% turnover, but if you go out, there's some with 200% or even 300% turnover, meaning nursing homes are seeing their entire staff turn over two or even three times over a calendar year. That was pre-pandemic data as well. We know things were very rough. Staff weren't well supported during the pandemic. We did a lot of research on this issue. We found staffing shortfalls when a COVID outbreak occurred at a nursing home, and then following that outbreak, we found a lack of personal protective equipment. We found limited access among staff to rapid COVID testing. And then finally, we published a piece in the Washington Post, myself, Brian McGarry, and Lori Porter, who I know has been quite involved in moving forward. But we published an op-ed suggesting nursing home caregiver was the most dangerous job in America. And there were huge spikes in COVID, obviously, and outbreaks across the country. And that led to death rates that were greater than even logging workers and commercial fishermen, which usually have the most dangerous jobs in America. Not surprisingly, given these risks and other issues around COVID, lots of workers left. So this is all workers, not just caregivers. This is, housekeeping and dietary, et cetera. And you can see the nursing home workforce lost, roughly 400,000 individuals. That's finally come back, but it took quite a while. It was just this summer that it reached its pre-pandemic level. How did how did immigration play into the sort of the figure I just showed you? Um, it's really interesting. We saw a lot of staff, as that suggests, leave the workforce. The vast majority of workers that have been leaving nursing homes are native-born workers. Foreign-born workers have been pretty consistent, and this is based on a paper Kate June and I published last year in Health Affairs. But um, foreign-born workers remained in those positions. And so one of the ways I pitched this is to say, think of how much worse this would have been if foreign-born workers had left at the rates that native-born workers left the workforce. And this is another exhibit from the paper that Kate and I put together. But you can see we just wanted to look at the correlation between the share of foreign-born CNAs across the bottom there with overall direct care staffing hours per resident day at the state level. And it turns out that those states with a high share of foreign-born staff actually had higher overall staffing. So Hawaii and California looked much better than West Virginia and Louisiana as examples. Once again, this would suggest that foreign-born staff contribute to the overall number of workers. They're not competing away jobs from native-born workers. They're actually growing the workforce. And this is a second. So Kate June has been one of my big collaborators on this research agenda. And you can see here, it's really interesting. This is a paper that's in press at Medical Care Research and Review. And we basically wanted to track over time what did it look like? And the red line there is March 2020, the pandemic. What did it look like pre-pandemic and post-pandemic for facilities with a lower share of immigrant staff versus a higher share? And so the higher share have more staff, not surprisingly. They're the sort of the triangles on top there, and then the circles on the bottom are those with a lower share. And you can see before the pandemic, we have what researchers call parallel trends. It just looks really nice. I know they're not equal, but they just kind of run nicely together. No, when we tested this, there's no difference in the pre-trends, if you will. Afterwards, however, nursing homes with fewer with a lower share of immigrant staff saw a 9.2% staffing decline, whereas those with a greater share saw a 7.2% decline. So those with immigrant staff, as we suggested in that earlier study, were better able to withstand the departure during COVID. And this is looking at turnover. So here we're just looking at the correlation, and it turns out nursing homes with greater shares of immigrant staff also have lower turnover during the pandemic. And this just fits with the idea that immigrant workers were much more likely to stay in their positions, whereas native born workers were much more likely to leave. So these are these studies sort of highlight correlations and interesting relationships, but they're not causal based, and we acknowledge that. And there may be something different about where immigrants choose to work, for example. And so um, I worked on a study with my colleagues John Gruber and Brian McGarry, and we published, this is forthcoming in the American Journal of Health Economics, where we really wanted to look at what was the effect of immigration on nursing home staffing and nursing home quality, and also on wages. Can we sort of get at some of these more causal questions? And you really can't randomize, obviously, immigrants to different parts of the country or to different nursing homes. And so we looked over time at what happens when you have a change in immigration, and what happens with those changes in immigration within a local area on nursing home staffing, wages, and quality. And I know not everyone's a methodologist on the call, but we use something called instrumental variables, which mimics randomization, where we come up with an instrument for where individuals choose to immigrate to. And we use this instrument, if you will, and it's based on the propensity of certain immigrant groups to locate in certain parts of the country. And then we use the national flow overall of immigrants of certain ethnicities to instrument for the actual immigration of, within an MSA. So we're trying to, as best we can, mimic a randomized experiment where immigrants might go to different MSAs. And the results, I think, are pretty interesting. So we focused on female immigrants because most of the workers, as I showed you earlier, in nursing homes are female. And we found a 10% increase in female immigrants to an MSA leads to a 0.7% spike in CNAs, about a similar spike in LPNs, and a 1.1% increase in RNs. So relatively big effects on staffing, and no impact on wages, by the way. So this was, remember, a big concern I mentioned earlier with some of the prior studies. Are they going to, when we have an influx of immigrants to an area, will they bid down wages for native-born workers? No, is the answer. Uh, and anyone who operates a nursing home is probably, hopefully, nodding their head. They need all the workers they can get. And so the idea that, oh, we can turn away native-born workers, or we can offer lower wages, no, the demand is pretty inelastic for additional workers. They'll be able to provide better care with more workers. This isn't kind of competing away jobs for native-born workers or competing down their wages. What about quality? We found also really strong effects on quality due to immigration. A 10% increase in female immigrants again led to a 0.7% decline in readmissions, a 0.8% decline in pressure ulcers, and a 1.5% decline in infections. It's hard to sort of interpret these, but when we sort of did some back of the envelope comparisons, these are similar to a lot of policies that we recommended in that NASEM report, and we spend a lot of time debating. We can get just as much from immigration policy as we can get from Medicaid payment rate increases or minimum staffing standards. Remember the minimum staffing rule? So here's a way that we can really encourage a lot more workers and a lot of good outcomes, um, uh, uh, similar to policies that have been pretty contentious. It's often hard to find additional dollars in a Medicaid budget. Minimum staffing standards are hard to implement. immigration policy should be a really great way to increase the workforce and actually encourage better outcomes. As a companion study, once again, Kate, June, and I, we took this same approach with the so-called shift share instrument I explained earlier, and we looked at just the role of immigration in mental health in nursing homes, and we found very similar positive outcomes there. Immigration reduced diagnoses of depression and anxiety, use of antidepressant and anti-anxiety drugs, and self-reported symptoms of depression. So even in a very focused kind of part and a very important part of nursing home care in terms of mental health, um, immigration really works. And this is another question, so maybe a good point to just say, like, people often ask me when I present these studies, do you think these workers are just as good? And I say the effect sizes are the same we get from minimum staffing standards, from Medicaid rate increases. By all appearances, it's really about getting more workers, and these workers are quite productive in terms of producing better outcomes. So no difference that we're able to detect between native-born and foreign-born workers. Um, Really recent work, so kind of hot off the presses here. So I told Alice and Claire and Jennifer I was going to include something kind of very new here. So this just came out last month. My colleague Brittany Barnes, who's a PhD student here at Harvard, she's very interested in immigration and the home and community-based services workforce. And so she put together a really nice study on this issue. And I just want to show you a couple of exhibits. I know our big focus today is on nursing homes, but you're able to see some of this shift that we were talking about. So let's start on the panel on the left here, exhibit 2. You can see the nursing home workforce is shrinking. And once again, it's largely shrinking because native-born workers are leaving. But you can see foreign-born, whether it's naturalized or non-US citizens, are remaining pretty consistent in nursing homes. But when you flip around over to HCBS, they're really helping to grow the workforce there. Yes, we're seeing an expansion in native-born HCBS workers, but a lot of that expansion is being driven by foreign-born workers. And indeed, if you ever get to publish in Health Affairs, they'll make you even put the sort of main result in the title. And so there it is. Foreign-born workers make up half the increase in the direct care workforce in home and community settings over the 2012 to 2022 time period. And you can see that overall, this kind of nets out in the bottom panel on the left there, where we're seeing a shrinking in the nursing home workforce, a growth in HCBS, but we're definitely seeing an expansion. And in Exhibit 3 on the right, there is just the percentages, and we're seeing this growth in foreign-born workers, especially those that are naturalized in terms of their overall share. One final just exhibit from that paper, and I think I made this point earlier, we have quite a bit of heterogeneity across the US in terms of the share of the workforce, the direct care workforce that was foreign born. So we have states like Florida and California and New York that have really kind of strong shares. And then there's other states like West Virginia and South Carolina, Louisiana that are much lower. And so it's worth thinking about as we put policies in place, even minimum staffing standards. States like California and Florida and New York are better situated to handle those because they're able to leverage foreign-born workers as opposed to some of these other states. I wanted to then sort of conclude with some thoughts on, how do we grow this workforce? I realize I started the talk by saying that there's a lot of threats to immigration and this workforce, and the quotes from Katie and Deke, and I think things are quite disconcerting right now around this issue. I would say even when we started this research agenda, I wouldn't have said the U.S. has a very I don't know, balanced or comprehensive, structure to thinking about pathways for nursing home workers to immigrate to the U.S. So um, there's sort of two broad pathways that workers get visas, permanent or temporary worker visas. Most are for what we would call skilled, and I don't love that term. It basically means higher paying. For permanent visas, EB3, that vehicle covers all workers, but only about 10,000 of those workers annually across all industries. So that, the nursing home industry needs a lot more than 10,000. For the temporary visa pathway, H-2B covers non-agricultural work, but most of that is outside of long-term care. Think of landscaping or housekeeping. It's really interesting. Most long-term care workers arrive through the visa classes for asylum or family reunification. So once again, we don't have a very intentional, I think, immigration structure policy in terms of building the long-term care workforce. We could be much more intentional about policies. A couple of ideas. Of how we might do this going forward. The U.S. has occasionally used H-1A and H-1C to grow the RN workforce. That's been very kind of directed. We're going to have this many foreign-born nurses from the Philippines, for example. We could obviously target this much more broadly for long-term care, RNs, LPNs, CNAs. We're not the only country that's interested, by the way, in having these workers come and care for older adults and contribute to their economy. Countries all over Europe are interested in attracting caregivers. Canada's actually set up a really innovative program they call the Fast Track program, where caregivers can move to permanent residency more quickly than other immigrants. So the U.S. could be, once again, I'll use the word intentional or strategic about how they set this up. I think to date we've unfortunately been a bit haphazard, and that's led to I think some of the gaps we currently have. Um, this issue or question always comes up, so I'm gonna take it head on, but I'm happy to talk more about it. Someone usually puts their hand up and says, "Dr. Grabowski or David, you're trying to do this on the cheap. You're trying to underpay our workforce. You're trying to, why don't we pay our workers a living wage?" And my response is always yes. This isn't an instead of. Immigration is part of a broader package of reforms. A lot of those were included in that National Academy's report. I wrote this piece that's up here back in 2021. It was back when things looked really bleak in nursing homes in terms of COVID. And the whole point was there's a lot of work to be done. And that's really what the National Academy's report was about. That's what moving forward is about. I said at the time, and I still hold, like if someone put me in charge today, I'd start with the workforce. And this is what I kind of laid out in that piece. We want to work towards better pay and benefits. Once again, I'm a big supporter of minimum staffing standards. I think we need higher reimbursement rates, and we need to ensure that those reimbursements are going to caregivers. And that's really what I mean by increased financial accountability. We need to provide opportunities for career advancement, and we need to make it a better place to work. So immigration reform, yes, but part of a bigger package, because this isn't because we can't, we don't want to pay, or we don't want to make this a job worth having. No, we can do both here. Um, Parting thought, and then I can't wait to hear questions and comments. Um, I this isn't going to happen accidentally. We need policies like the ones listed on the prior slide that are really going to grow the long-term care workforce. I think immigration reform in a positive way here has to be a piece of that. and I think can and ultimately will be a piece, but it can't be the only piece. And so I'll stop there. I'll put my email up if anyone wants to follow up with emails or questions, but I'm happy to stop sharing right now. And Alice, turn it back to you for questions and comments. I see Teresa, you have your
Mhm.
hand up. Maybe you'll get the
Yeah.
first
She
word here.
she
Thanks.
will get the first word, but first let me just say, David, thank you. That was an amazing overview, very comprehensive, and I'm sure people were furiously taking notes. For this Q&A session, because we have a lot of people on the call, again, if you put your virtual hand up as Teresa has done, we will do our best to unmute you and let you go ahead and ask a question or make a comment. So Teresa will unmute you and you can ask Dr. Grabowski what's on your mind.
Okay, hello. I'm happy to be here. I'm a resident in a nursing home, and most of the staff and the CNAs, the RNs, and the LPNs are foreign born, like you said. And unfortunately, we don't have a way to give the CNAs um, a perfect, wage. A lot of them have to do overtime to make minimum payment. I mean, to earn a living. They're paying so little, and we have to value our CNAs because they are the ones that take care of the residents. The,
You're
the government has to come up with a better system of, getting foreign born workers to come and work, make the visa application easily accessible to them and not just in the tech industry because these are really needed. And if we have less staff, it means less quality care that residents get. And we have to understand that we shouldn't vilify immigrants because they do a very wonderful job in the nursing home that I live. In my units that I'm in, all the workers from the first shift to the second shift to the third shift are all foreign born. So imagine a crackdown on immigration like that, how it can affect the workers, which will in turn affect the quality care,
Yeah,
and Medicaid cuts also pay these workers. We have to bear that in mind.
right. Teresa, thank you so much. As always, Teresa's on our steering committee, and as a nursing home resident, she's always got really helpful comments such as those. So, David, what are your thoughts about any of
Yeah.
that?
Teresa said it better than me, so she should be giving the next one of these. That was awesome, Teresa. I 100%. I co-sign all of that. A couple of thoughts on policy and how we grow wages for CNAs, whether they're native born or foreign born. Uh, there's a lot of good evidence that wage pass-through policies, policies through Medicaid payment, that you have to direct those dollars to the salaries, wages of the caregivers is one avenue. Some states now, including Massachusetts, where Alice and I live, it's trying to hold nursing homes to spending some share of their dollars on direct resident care. A non-nursing home policy that actually has been shown to work really well is just raising the minimum wage rate in the state actually bumps up. And so there's some really nice evidence that actually raises wages. But I sort of have an all hands on deck approach to this, that like any of those, and including continuing with strong immigration to just grow the number of potential workers. Because and the other point I really love that you raised was just the idea of the first shift, the second, the third, who's working those second and third shifts and who's taking the most difficult shifts. And I have no doubt, and that's really hard to see in a lot of the data that we have, but I think you gave us a really nice kind of insight there and research idea. I would love to kind of peel that out a little bit more about, kind of who's working when, and just the sort of how many of these foreign-born workers are just the backbone of these nursing homes. So thanks for
Right. And related to that, who's supervising on those shifts and who's doing education, who's doing training? How often is the licensed nursing home administrator or the director of nursing showing up at 3 in the morning when, you know, those CNAs are running around with very large, you know, numbers of residents that they're caring for. And, you know, understanding what it's really like on those shifts. Nancy Stevens is another one of our nursing home residents over on the West Coast, and does a lot of advocacy in California and other states as well. Nancy, okay, I said your name and there you are. Go for it. We'll unmute you.
Nancy, will you raise your hand again so I can find you in the group? Ah, there you are.
Thanks,
Okay.
Claire.
There you
Thanks,
go.
Alice. Hi, Dr. Grabowski. Thank you so much. Great presentation. Couple of questions. I don't know how it relates to this specifically, to this presentation, but I read a couple of articles, and maybe you can let me know if there's any factuality to these things. But I read that the United States has not followed through on their agreements to contribute to economies where healthcare workers come. Yeah, okay. And then another thing too is who would I connect with to kind of gauge what the I guess current climate or opinion is on healthcare workers continuing to come to the United States, both from politicians or legislators and lawmakers in other countries,
Yeah, both.
and from the public.
Yeah,
Yeah,
thanks,
both.
Nancy.
Yeah, great questions. To the first one, this comes up a lot, and you hit the one question. There's probably others I forgot to hit in my presentation, but I get asked this a lot of like, well, what about the impact on these other countries? Like I mentioned, the Philippines, like that's a huge brain drain. If we grab all of their RNs and they come here, we need them here. And so like I agree. That's something we want to think about. And there is some really nice evidence that sometimes, as you noted, the U.S. has been great about helping, train workers. They return to their home country, but other times we kind of haven't held up our end of the bargain. And so thinking about doing this in a responsible way, that we're not simply grabbing workers from other country and not countries and not giving anything back. I think this has to be a two-way street. People want to come to the U.S., but also making sure we're giving something back, because otherwise it just doesn't work. And
Yeah.
on that topic, I'm working on a World Bank report right now and trying to think about this beyond the U.S. And so it's really timely that one country's kind of immigration gain is another's brain drain and work loss, and that just doesn't
work.
Doesn't add up. In terms of where to go in terms of advocacy, I really think going with Congress, although how fruitful that'll be, but in terms of like really lobbying representatives and senators around this issue, I think this is a bipartisan issue. I don't think this is a particularly partisan issue. Everybody benefits. It's all of us have are going to need care, and who's going to help provide that care. So I hope making that case to our representatives, that would be my sort of target here, because it's not and Alice, I don't know if you have different thoughts. It's not the state level. It's not CMS. This is really kind of about immigration.
This is about Congress. Yeah. And I would add to that, David, that one of the points we've made on a lot of these phone calls, and you guys have heard us say it, is there's so much misinformation and just a lack of information about these issues. And David does such a nice job of explaining things in plain language so that, it's understandable. But, immigration law and policy is complicated, and there's not easy answers out there. So I think you're right. And it's more of an issue of informing and getting information out there to people in Congress and the states as well, to a lesser degree. Okay, so we have 9 minutes left, and we have 3 hands up and great stuff in the chat. So I'm going to go to Patty Moore next, our wonderful colleague and advocate from Martha's Vineyard in Massachusetts. And Claire, if we can unmute Patty and she can ask her, and we'll just ask if you would make your comments or your questions pretty short. So Patty, go ahead.
Thank you very much, and thank you, Dr. Grabowski. I'm not optimistic on the issue of why people would want to move into our anti-racist attitudes today. So I'll leave that aside because I think that is a factor right now. But I am curious, my own feeling is that we need to expand our vision of what a CNA is and can do in this whole, and the role of the relationship between professional staff and the CNAs, because clearly in the greenhouse model, it makes a huge difference the type of person who is given responsibilities. And once they see the possibilities, then a very different kind of person wants to take that responsibility, which opens up, it should open up for us in the future some totally new conversations.
Mhm.
I'd love to have your comment on that idea.
Yeah, I love that. I both agree, and it'll attract a new set, and then it'll also grow a new set of workers
Right.
as well. Because when I did as part of our greenhouse evaluation, they would often say, like, other nursing home administrators would come to their buildings and say, "How do you find workers like this?" And they said, "They're the same people you have in your building, only we're empowering them and you're not." And so
Right,
you need to empower your.
People don't know what that means.
Oh, that's
right.
right.
That's right.
There's where our work lies.
Yes,
That's right.
I
That's
totally agree.
great. That's really great, Patty. And we are moving forward in many organizations on this call. So feel free to chat in what your organization is doing. Are talking about leadership, or talking about quality, or talking about support and management in a positive way, and all of that. So I couldn't agree more. I think we'll go to Grace next, and then I wanted to highlight a couple of the comments in the chat. So Grace, we will unmute you and you can ask your question. Go ahead.
Hi, thank you very much. This has been very interesting conversation. So I appreciate all the data too. So I don't have a question. I actually have a comment. Basically, you've presented a lot of great information. Obviously, we need to talk to legislators, and everybody needs to be on board, right? But we also need to disseminate this information not only to scientific journals and to healthcare providers and administrators, but also to the general public, because they are voting members as well. It also is going to help for them to hopefully reduce the bias and the preconceptions that they have toward immigrants, because that doesn't make it very inviting for people to even want to come to to this country. So those are some other things. I remember when I was in nursing school early on, that they said, we need to also be publishing these things in magazines, not journals only, right? But magazines that the average person is going to read, so we can reach the average person. And these are the people that are going to be affected by care, right? Because the population is aging. So just wanted to make those comments. Thank you.
Thank you so much. Go ahead, David.
Yeah, just really quick, Grace, I completely agree. And we've often tried to pair our scientific articles with pieces. I highlighted one in the Washington Post today. I don't know if everybody reads the Washington Post, but as an example of a outlet, and we've done a lot of that in The Hill and the Washington Post and New York Daily, News, New York Times. We've tried to kind of reach broad audiences. I put up that Politico piece. I know not everyone reads Politico. That's kind of wonky, but I love the idea of how do we reach people outside of our sort of
Right.
silo.
Right. And there might have been a time in our history where we could sort of joke and say, oh, well, we're not reading these things. And now we need to read these things. We need to be reading them. We need to be responding. We need to be commenting. And, again, it's all of our responsibilities now to say, wait a second, this isn't working. And how can we make it better when we've got all this research that you've done? So thank you so much for raising those issues, Grace. I just wanted to, David, there's one question in the chat here from Bethany Dizer. So Dr. Dizer is one of our close colleagues from the state of Michigan. And she's asking about the unemployment rate in an area and if there's a way to control for the unemployment rate.
Yeah, so in the paper that I mentioned, we're sort of controlling for local area, but you're raising a great comment that the unemployment rate, other sort of macroeconomic factors kind of matter in a state, and trying to think about immigration separate of those would be a mistake. So, is the economy good? Is the economy bad? Are there, are native-born workers more likely to take these jobs? And I think that probably goes much more with the unemployment rate, much more with sort of local economic factors, much like COVID, where a lot of native-born workers left, but foreign-born workers were a little bit more consistent. So it's a really important point.
And Bethany and Michelle Macia is on this call too. There's just a lot of workforce that's being done in the state of Michigan and lots of other states too. So with just 3 minutes left, I wanted to just highlight one other comment that was made by Senator Richard Moore, who's my colleague here in Massachusetts and has been in the state legislature for a while and is now doing a lot of advocacy here. And, he's just talking about a lot of the issues that we all read about every day: federal government cuts to Medicaid, deporting non-criminal immigrants, eliminating staffing minimums, and, with, changes by the nursing homes and how they are able to staff, increased adverse events of all different kinds. And should we be requiring nursing homes only to admit and retain a number of residents that can be safely served? That is actually already in the regulations. They are required to do that. But to your point, Senator Moore, I think you're highlighting that things are really in a way that we must, sit up, pay attention, and really take action now. So I might just, in the last minute here, I wanted to turn it over to our policy director, Jennifer Baker, who can wrap us up. But I wanted to first of all, thank you all for being on this call today. This was a great conversation. Dr. Grabowski, we were so grateful. I think we'll probably invite you to come back again in a few more months.
Too, yeah,
because you're never busy doing anything, right? And
never too busy to join this group. So
okay, well, that's good to know.
Questions, everyone. This was awesome.
Yeah. It was great. And our next coalition conversation is on September 23rd. So it's also this month from 4 to 5 Eastern. And it's going to be a coalition conversation about household models and our household model work group that's done a tremendous amount of work. So I can see in the chat, everyone's very grateful. And since you talked so much about immigration policy, and Jennifer is our policy guru and lead, Jennifer, we'll let you close it out today.
Goodness, it's a hard act to follow and to wrap up here, but just have so appreciated the conversation and the questions and comments in the chat. And I think one of the things that we at the Moving Forward Coalition are just so committed to is making sure that the people who live, work, depend upon, and provide care in nursing homes, that their voices are amplified. So that everyday people see themselves in the policies and the conversations that we're having. And so we welcome all of you to join us in that commitment and to suggest different pathways for us as a coalition to be connecting with folks on the ground. So thank you very, very much for this just really thoughtful conversation. There's lots of opportunities for growth, and with all of our powers combined, we'll find ways to navigate through and find the spaces of consensus to do that. So thank you very much.
Perfect. All right. Thanks, everybody. Have a wonderful rest of your week. We'll see you on the next coalition conversation.